Great. Well, thanks, Maria, for such a kind introduction, and thanks for getting my name right. That one wasn't a hard one to get. And I'm particularly appreciative to be back here in Portland in the great Northwest, where I grew up in Seattle, and today have the pleasure of talking to you about novel approaches for Hodgkin lymphoma. So when we look at classical Hodgkin lymphoma, which is the major group of the Hodgkin lymphomas, there is a relatively complex diagram that helps to describe how we manage patients in the front line and in the relapse setting. And I will review a number of points regarding these issues. For early stage patients, they are typically divided into those patients with favorable disease characteristics and unfavorable disease characteristics. And very commonly, patients with advanced stage disease, including those with stage 2 disease who have B symptoms and those with stage 3 and stage 4 disease, are treated with chemotherapy-based approaches. When you look at the role of PET scanning in these diseases, this is a role that is emerging over time and helping us to stratify patients into different subgroups that have better or worse prognostic risk, and then to helps us to define what the subsequent lines of therapy could be. And then I'll review also some of the roles of involved field radiation, which is now typically called involved nodal or involved site radiation. The radiation oncologists keep changing the names of their radiation over time to demonstrate to us that they're doing something better as time improves. And discuss some of those roles in both early stage favorable and unfavorable disease, and discuss a number of novel therapies now that are available for patients with relapsed and refractory Hodgkin lymphoma. So first, to discuss early favorable Hodgkin lymphoma. So this is a guideline that we put forth as part of the American College of Radiology, which might seem an unusual group to be involved in lymphoma guidelines, although this group has subgroups of medical oncologists that are involved both in imaging modalities for lymphomas and in the use of therapies for lymphomas, and a subgroup that is particularly focused on radiation oncology. And we covered some of the favorable prognostic and unfavorable prognostic and have a number of guidelines for management of Hodgkin lymphoma. For patients with favorable stage 1 and 2 disease, typically an abbreviated course of chemotherapy followed by radiation therapy is the current standard of care. Although there was a paper just a few years ago in the New England Journal of Medicine from the German Hodgkin study group that helped to modify the ways that we think of these patients just recently. So in this publication, this group looked at the use of a more abbreviated course of chemotherapy, so 2 cycles of ABVD versus giving 4 cycles of ABVD, and then patients were additionally randomized to either a lower dose 20 gray of radiation or a standard dose of 30 gray of radiation. And what you see here are the chemotherapy groups bunched by radiation, because there did not appear to be a significant difference when stratified by those radiation groups. And what you can see in terms of both progression-free survival and overall survival, that there were no clear differences between the group of patients who had 2 cycles of ABVD and those who had 4 cycles. And while this represents a significant advance for patients with early stage favorable disease, I think very important to consider in this particular population are what the criteria that were used for favorable disease. And this approach to using just 2 cycles of ABVD really should be limited to what the German Hodgkin study group defined as favorable characteristics. So those patients who had no large mediastinal adenopathy, who had a erythrocyte sedimentation rate of less than 50 if they had no B symptoms, or less than 30 if they had B symptoms, those patients who had no evidence of extranodal spread of disease and had only 1 or 2 sites of involvement. I think this is also important because there are a number of other criteria for defining favorable versus unfavorable disease, and shown here are the ERTC criteria to the left, which are slightly different. Additionally, there are slightly different criteria that have been put forth by other study groups. So Next, turning to early unfavorable Hodgkin lymphoma, and the approach for this particular population has typically been to give ABVD for 4 to 6 cycles of therapy and then to consider involved field radiation to bulky sites of disease. For patients who do not experience responsive disease, to consider biopsy and then high-dose therapy and stem cell transplant, which I'll move to in later portions of the talk. Like for the favorable category, there is an American College of Radiology guideline that we put forth for this population as well, where we have looked at patients with unfavorable disease in this group as those that have a bulky mediastinal mass defined here, or other patients with absolute measurements that constitute having large bulk of disease, where radiation should be included as part of their therapy. However, there have been other approaches to try and modify this, and this is another study from the German Hodgkin Study Group where they looked at giving a more intensive form of chemotherapy, the BEACOP regimen, which I'll also talk about for patients with advanced stage disease, and compared it to ABVD in the early unfavorable Hodgkin lymphoma population, where they compared patients in the age range of 16 to 60 who had unfavorable characteristics defined by these criteria, and then randomized them to either ABVD for 4 cycles followed by 30 gray of involved field radiation versus 2 cycles of the escalated BEACOP intensive chemotherapy regimen followed by 2 cycles of ABVD receiving the same 30 gray of radiation. And I think importantly, when you look at this trial was closed actually early in part because there seemed to be a benefit from freedom from treatment failure in the group that got more intensive chemotherapy. And when these data were presented and then later published, what you can see is that both in terms of 5-year freedom from treatment failure and 5-year progression-free survival, there appears to be an advantage to what's listed here as Arm B, so the BEACOP followed by 2 cycles of ABVD regimen. I think important to note, and what is commonly confused in this trial, is this really is not BEACOP versus ABVD, but a short course of BEACOP followed by ABVD and radiation, with the hopes of producing more responses earlier from that more intensive chemotherapy regimen. And one of the things that we've seen that's been a common problem with BEACOP is that it increases the risks of infertility in these young patients with Hodgkin lymphoma, with nearly everyone with BEACOP who receives BEACOP in the advanced disease setting becoming infertile after therapy. When they looked at this with this short course of BEACOP, that really was not true. And there were no differences in terms of infertility in this trial with relatively short follow-up, and no differences in terms of late secondary effects like myelodysplastic syndrome or AML. And the acute toxicities of those 2 arms are shown here, Arm B being the BEACOP for 2 cycles followed by ABVD, and Arm A being the group that got ABVD for 4 cycles. What you can see here is that in terms of the acute grade 3-4 toxicities, there was markedly more toxicity in Arm B with more leukopenia, more alopecia, markedly more thrombocytopenia, and more anemia, constituting a plethora of more grade 3 cytopenias, and slightly more grade 3-4 infections. But there are no differences in treatment-related death and no differences in secondary neoplasia rates, as I mentioned. The take-home message from this trial from the group that presented it suggested that this could be a more intensive regimen that you could apply to hopefully be able to improve outcomes for patients with early-stage unfavorable disease. And so they recommend intensifying therapy with BEACOP for 2 cycles, followed by ABVD and involved field radiation for this particular group. And they've implemented this as the standard of care strategy for their follow-up trials. I think what remains to be seen from data from this trial and trials that follow are whether there is an overall survival advantage for patients who receive this more intensive regimen up front, whether there are markedly more or markedly different very late effects, which we can see occurring in this patient population, and I'll touch upon some of those in the coming slides. And for those patients who ultimately relapse with Hodgkin lymphoma in either one of these two trial arms, whether there are differences in the salvage rates with chemotherapy and autologous stem cell transplantation, or some of the novel therapies that I'll talk about at the end of the talk. So I think there still are a number of unaddressed questions with this trial. As of right now, for early stage unfavorable patients, ABVD tends to be the standard of care in most countries outside of Germany. So some of the things that tend to be issues for patients with Hodgkin lymphoma that are long-term survivors are fairly significant events. So secondary malignancies I talked about, late cardiovascular disease from the use of anthracyclines and from the use of radiation to the chest, other treatment-related factors like thyroiditis or thyrotoxicosis or hypothyroidism, and other exposures that happen to the same population that can compromise their quality of life and potentially quantity of life. I think importantly, when you look at some of the standard radiation fields that are given to patients with Hodgkin lymphoma, these typically involve radiation that covers at least part or most of the heart, depending on the size of the bulky disease. And this is just a schematic of some of the areas covered by radiation, and can also cover the great vessels and the carotids. And so there are significant risks of carotid disease as well as cardiovascular disease in these patients as late effects that can occur 5 or 10 or really 10 or 15 years out from their therapy. And if you look at the incidence of these rates up to 20 years, they are relatively appreciable, being about 20 to 30% of these patients that have some form of cardiovascular disease. So I think this is an important event to consider, and important to consider in the ways that we manage these patients, that we may be trading cure of their Hodgkin lymphoma for late events in terms of cardiovascular disease. And we have a particular cardiologist at our center who is interested in these late-stage complications and has developed what's a new subspecialty with a number of group of cardiologists across the country, cardio-oncology, where they are focusing on these late events following Hodgkin disease and other populations of patients that get chest radiation or get anthracycline-based chemotherapies. And this just lists a number of those events that can occur in the greater than 10-year range or 10 to 15-year range, and these slides are in your packet. So turning now to patients with advanced Hodgkin lymphoma, the story of advanced Hodgkin lymphoma really is an interesting one that extends over several decades when you look back to really the advent of combination chemotherapy for malignancies in general, with MOP chemotherapy being really relatively one of the first combination chemotherapy regimens ever used in the 1960s, and one of the ones that was used that demonstrated cure, that chemotherapy could provide a curative approach for patients with lymphoid malignancies. Following that, in the 1970s, the group in Milan essentially developed ABVD as really the only four active chemotherapy agents that they could come up with at that time that were not included in MOP. So there was not a whole lot more science than that went into the development of this regimen initially. And they found that in patients who relapsed after MOP, that could potentially produce complete responses in large numbers of patients. I think what's interesting about this over time is that if you look at the ABVD chemotherapy regimen, it's been compared to the hybrid chemotherapy regimen and to a whole host of chemotherapy regimens over time, where each of these chemotherapy regimens were initially designed and evaluated in phase 2 clinical trials and suggested that they had benefits that were greater than ABVD would likely be. And then when you look at the series of randomized controlled trials comparing ABVD to each of these regimens, ABVD always came out superior or came out equivalent with markedly less toxicity than these more aggressive regimens, suggesting that ABVD has been the long-standing standard of care since the 1970s for patients with advanced stage Hodgkin lymphoma across a number of comparative trials. I think the other thing that makes it very hard for many of these novel agents that I'll talk about to move into the front line is that the outcomes with ABVD have been so successful that improving upon those outcomes in randomized trials has become very difficult. Now, this was a trial that was so one of the regimens that I'll skip over the trial data on that did move forward was the Bayakop regimen in Germany. And they performed a trial that was shown on the last slide, comparing Bayakop to the hybrid regimen of COP-ABVD that showed that Bayakop had benefits in the advanced stage population of better freedom from treatment failure and better progression-free survival, and suggestion of a benefit in overall survival. But this trial that was published in the New England Journal of Medicine a couple of years ago, I think is actually the more important trial to address the question of which of these two regimens is the best upfront regimen to use. And what they did was they took patients with Hodgkin lymphoma who had advanced stage disease, so those with stage 2B, 3, and 4 Hodgkin lymphoma, and stratified patients by their international prognostic score of more favorable versus higher risk patients, and then randomized patients either to ABVD for 6 to 8 cycles at the discretion of the treating physician at that time, and then versus getting Bayakop for dose-escalated regimen for 4 cycles and the standard regimen for 4 cycles, which was hoped to be slightly less toxic than the dose-escalated regimen where it had all of those late effects that I described. And then I think importantly in this trial is that they applied the same strategy to all patients that relapsed on this trial. So for patients who had a complete response or partial response, if they had a bulky disease or a residual mass, they got radiation to that site. For patients who had any signs of progression of disease or relapsed at any point, they went on to high-dose chemotherapy and salvage therapy with transplant. And the same was true for the group that got Bayakop. And when you look at the outcomes of this trial, what this shows is that this trial really recapitulated the same data that were seen in the German study group. So if you look at patients who got either ABVD or got Bayakop in this trial, there was a higher complete response rate at end of treatment for those patients who got Bayakop, both before and after radiation. There may have been a slight increase in toxic deaths, but these really were not statistically significant. And markedly fewer patients with Bayakop went on to receive salvage therapy compared to those who had ABVD, suggesting that perhaps in the frontline setting that Bayakop might be a more intensive regimen that can produce more remissions. But this is really the important part of the trial. If you look at the patients that went on and then all received standard salvage chemotherapy and stem cell transplant, and look at the secondary freedom from progression, so freedom from progression after the transplant, patients who received ABVD caught up to those who received Bayakop, and there was no difference in freedom from progression after the transplant, and no difference in 7-year overall survival after the transplant, suggesting that salvage transplant can salvage those patients with ABVD who relapse versus those who were on the Bayakop arm who were much less likely to benefit from salvage therapy and transplant. So the author's conclusions, and I would agree with all of these, is that Bayakop had freedom from treatment failure, freedom progression that was superior in 12% of the patients, but after the end of therapy with salvage therapy and transplant, the group who got ABVD caught up. And overall, there was perhaps over-treatment of more than 70% of the patients on the Bayakop arm who could have been cured by ABVD in the first line and avoided that toxic therapy of the Bayakop regimen and the risks of infertility and secondary malignancies. So in the United States, there has been a recent intergroup trial that was led by the Southwest Oncology Group, SWOG trial 0816, where PET imaging was used to be able to identify patients who might benefit from more intensified therapy. And this is just one of several trials that has used this type of approach using PET-directed therapy to identify patients who might benefit from more intensive regimens. And so for all patients receive ABVD for 2 cycles of therapy. For those who were PET positive at the end of 2 cycles, they went on to either receive escalated Bayakop if they were standard patients with classical Hodgkin lymphoma who had stage 3 or 4 disease, or receive standard Bayakop for HIV positive patients who were eligible for the trial, although relatively few were enrolled on this trial. This trial has now completed accrual, and we're waiting for final results to see whether using a strategy of Bayakop later on might provide benefits for those patients who don't achieve benefits after being PET2 negative. So I think the other thing that's important to remember is the role of salvage therapy and stem cell transplant that I alluded to in the trial previously. These are sets of criteria that can be used to identify those patients that are most appropriate to send to salvage therapy and stem cell transplant. So relapse within a year, relapse with B symptoms, relapse in an extranodal site, or relapse at a previously irradiated site. And there are other potential indications that are somewhat controversial. These are markedly older data that were first published in the ASH book in 2003, but show the clear benefits of using autologous stem cell transplant in the relapse setting for patients with Hodgkin lymphoma, whereas if transplant is given at a later date, which is relatively rarely done now, and even at that time was rarely done, that the benefits of transplant are markedly less. So stem cell transplant still remains the standard approach for patients with relapsed Hodgkin lymphoma. And these are data from our group that recapitulate that in a more modern setting, showing that patients who have been salvaged with stem cell transplant and followed beyond 5 years, really there are few or no relapses beyond that point. Now, turning finally to the novel agents that are now out there and available for patients with relapsed Hodgkin lymphoma, and there are a number of potential approaches that can be used, and some of these I will address. So this is a very nice review that was put together by Anis Yunus and colleagues at the tail end of last year, looking at the pathways that might be appropriate to address in patients with Hodgkin lymphoma, both in the relapse setting and potentially maybe in earlier lines of setting if we can identify patients who have unfavorable disease. So one approach that's been commonly looked at, now building on data from the non-Hodgkin's lymphomas that you'll hear about in the following talks, are the use of monoclonal antibody therapies for Hodgkin lymphoma. And CD30 is a surface molecule that has been used, and CD40 is another one that is now starting to be looked at. When we first looked at naked antibodies in patients with Hodgkin lymphoma using anti-CD30 antibodies, and we were involved in some of those early trials, that was a trial that really was unsuccessful. And part of the reason why it was unsuccessful is that what we found is when naked monoclonal CD30 antibodies bind to the CD30 receptor, they bind to that receptor, and then that receptor is then internalized, and then those anti-CD30 molecules can't stimulate the immune system to be able to attack those lymphoma cells, as has been seen with rituximab and other antibodies, anti-CD20 antibodies in the setting of non-Hodgkin's lymphomas. And so intelligently, a number of companies have looked at the role of binding to that CD30 antibody, linkers, and then chemotherapy adjuvants, and brentuximab vedotin is one of those that has moved forward in this setting. Likewise, PI3 kinase inhibitors, which you'll hear much more about in the CLL and non-Hodgkin lymphomas talks, are something that are being explored in Hodgkin lymphoma. BKM120 is a dual inhibitor. Cal101 is now the approved agent, idialisib, and IPI145 is another one that is being looked at potentially in Hodgkin lymphoma. Other stimulants of the immune system, nivolumab, which is shown here in this cartoon looking at PD-1 and PD-L1, is being looked at. And there are a number of signaling molecules, both looking at the NF-kappa B pathway, looking at the JAK-STAT pathway, looking at MEK pathways and mTOR, that look to be signaling mechanisms that might play a role in Hodgkin lymphoma, similar to the ways that they play roles in non-Hodgkin's lymphomas. And the HDAC inhibitors likewise have been looked at in the Hodgkin lymphomas. So brentuximab vedotin is now FDA approved for use in patients with relapsed Hodgkin lymphoma. This is an agent that is used at a dose of 1.8 milligrams per kilogram and given on an every 21-day basis, and was initially used in this trial up to a maximum of 16 cycles. It now is approved for continuation of use as long as patients are responding and not experiencing toxicity, and was looked at across a number of CD30 positive malignancies, including Hodgkin lymphoma. And what you can see here in this waterfall plot for Hodgkin lymphoma are the patients who had complete responses, shown here in the blue, partial responses, shown here in the yellow, and stable disease, shown here in some color that I can't tell from this point. I think it was green originally. But you can see in this waterfall plot that the vast majority of patients who were enrolled on this trial had responses to brentuximab vedotin. And these commonly in the Hodgkin lymphoma population were those patients who had already received ABV in the upfront setting, had already received salvage therapy in the relapse setting, and then gone on to autologous stem cell transplant, or were occasionally transplant ineligible. And these are the progression-free survival curves for that population, showing here the median progression-free survival with brentuximab vedotin, shown in the blue, and the median progression-free survival with the last therapy that patients administered. And the brentuximab compared favorably with a median progression-free survival of 7.8 months versus 4.1 months in this population. I think important to note in this particular population is the risk of peripheral neuropathy, particularly peripheral sensory neuropathy in this patient population, where this toxicity can occur as you continue patients on brentuximab vedotin. And if this is not attended to, that sensory neuropathy can progress to motor neuropathy, and patient can ultimately become wheelchair bound and more debilitated. So as the strategy towards using this in later lines of therapy and with more cycles of therapy, this is something that really needs to be attended to. The other adverse events were typically grade 1 and grade 2 adverse events. The relative incidence of grade 3 and 4 adverse events on the trial were quite minor, with the exception of neutropenia. Turning to the HDAC inhibitors in Hodgkin lymphoma, these exert effects through the epigenetic effects on gene expression, and there have been a number of trials that have looked at HDAC inhibitors in Hodgkin lymphoma that are under review. The most notable is a trial involving panabenostat that has been under review at the FDA for quite some time. Those data are shown here, where in 51 patients with panabenostat, the overall response rate was 27%, with a complete response rate of 4%, and it has been compared to other agents. These just provide comparative data for a number of agents that have been looked at in the relapse setting for Hodgkin lymphoma, including brentuximab, with the data that I showed you earlier, everolimus, the mTOR inhibitor, which had an overall response rate of 47% and a CR rate of 5%, and looks to be an active agent in this particular patient population, and the host of HDAC inhibitors that are shown at the bottom of the slide. I mentioned PD-1 antibody earlier, and this is an agent that is moving forward in a number of non-Hodgkin lymphoma and Hodgkin lymphoma as an active immunostimulating agent that appears to have interesting properties in that it can produce responses in patients that are chemotherapy refractory. The data on pitolizumab is the agent that's has moved forward most rapidly, but nivolumab is now being looked at very closely in this population, and lambrolizumab, an agent that's very difficult to say and has moved a little bit slowly, hopefully not just because of the name, in clinical trials. The last agent that I'll touch upon is lenalidomide, which really has pleiotropic effects. We're starting to uncover the role of lenalidomide in myeloma more carefully, as it involves cereblon, But in Hodgkin lymphoma, these pleiotropic effects really have not been worked out to a greater degree, but it does appear to have activity in this setting. So I showed you this in the table, but this is just a graphical representation of a number of these agents that look to be active in clinical trials in the phase 1 and phase 2 setting, both producing favorable overall response and in some cases complete responses. It's really at this 30% line where some of these agents are crossing over that we would think that these would be the kinds of agents that should move forward for patients with relapsed Hodgkin lymphoma as potentially approvable agents, either in trials that are aimed at this targeted poor risk population or as randomized trials. So with that, I'll stop, and I'm happy to take questions afterwards or questions after all the speakers are finished. Thank you for your attention.